Good evening, everybody. Welcome as you join our webinar, this very special edition with Dr. Karen Herbst and members of our clinical team. We are going to devote the session to Dr. Karen Herbst's latest research. I'm Shari Fetzer, I'm chair of Lipedema UK. I don't think Karen needs much of an introduction. She is so well known in the field of lipedema. She was the first person, I think, who really an authority on it. Certainly in my experience, there were lots of people who maybe were in clinical specialisms who were looking after patients. Certainly here in the UK, we had some really good clinical expertise. But Karen sort of brought it to the masses, I think, didn't you, Karen, if I can use that expression, by your activities, your research papers, your associations. And I think the fact that you always put the patient first, that you have such a patient-focused aspect to your work, that you're always giving out there presentations, information, your diagnostic videos. You have been at the foremost of sharing information about lipedema and actually looking for ways to help patients. So I think this latest research is something that we should all know about, and your findings, particularly because there is such a contentious aspect to edema. So over to you, Karen. Thank you so much for joining us, and we're really pleased to have you this evening.
Thank you so much to you, Sherry, for the invitation, and to Lipedema UK. And I just continue to marvel how I can be sitting here in Tucson, Arizona, and I'm giving a talk in the UK. So that's just, I really like that part of technology. So I am going to, well, let me just tell you, I'm from the Roxbury Institute, and I am their head of research, and I'm also trying to come up with new ways to diagnose and prevent lipedema. And I'm going to tell you about a study that was a glint in my eye years ago, and I started to work with Eric Anzart from Lymphopress, and he finally gave me the go-ahead and said, we will pay for a study on lipedema. And this is the study. It was done with people at the Carolina Vein Center in North Carolina, USA, and I'll show them to you at the end. So I am the Chief Medical Officer for Lymphopress. So I know you all know about lipedema, but I just wanted to say a few things. I still believe that lipedema is a connective tissue disease, and sometimes we say adipose connective tissue disease. And we do know that the tissue is very fibrotic, so it's very difficult to get rid of. What is a little contentious is, where is lipedema tissue? And in my opinion, it is on the arms and the legs, but it's also in the pelvic area, often in that suprapubic area, also on the lower abdomen, sometimes on the upper abdomen. And in these areas, it is painful, it can feel heavy, and it can grow to such an extent that it affects mobility. Another interesting aspect about lipedema tissue is that there are large and small adipocytes. And what I researched a number of years ago was, is there fluid in fat cells? And, you know, we think of fat cells as only having fat, but actually the larger a fat cell becomes, the more free fluid that it has inside of it. And relative to, for example, muscle, fat has very little water. But I think it is important to know that as we grow fat, that our fat contributes not only triglycerides, but also water to our tissue. And that's going to come up throughout the study, because what we're trying to do with a pump is to decrease water in the tissue. We also know that lipedema and lymphedema are linked. Well, how is that? Well, we know that lymphedema and swelling are notable comorbidities in lipedema. And we know that the risk of lymphedema increases with lipedema stage and body mass index. And we know that this fluid in the tissue is due in part to increased permeability of the small blood vessels. So we know that fluid is coming out of the blood vessels into the tissue, and that the tissue has to handle that. And with Eva Sevic's group a couple years ago, we showed that the lymphatic vessels pump really fast in even early stage lipedema, so that the the lymphatics are trying to get this fluid out of the tissue. So we know it's there, and we are pretty sure it's coming from the microvessels. Why is it coming from the microvessels? We think there's an inflammatory insult, and we don't know what the inflammation is. And this is a brand new paper that came out of Dr. Michelini and Dr. Cinti's labs. And you could see here's a capillary, and these are endothelial cells, and they're very nicely connected. And then you get this hole right here. And this used to be an endothelial cell, and you can still see the connections here on either end, but this endothelial cell has basically been destroyed. And so you can imagine you're going to get a lot of leakiness out of the capillary when this cell is no longer a barrier. And this is a fabulous paper if you have a chance to read it. It is kind of complex, but Dr. Cinti said that the destruction of the blood vessels in lipedema tissue was something he'd never seen in 45 years of practice. So how do we manage this leakiness in lipedema? So conservative therapy, super important. Compression garments, manual lymphatic drainage therapy, deep tissue treatments to reduce the fibrosis, and active compression or pneumatic compression devices. And then also surgical intervention to remove the lipedema tissue, especially the fibrotic components of it, decongest, and then removing excess skin or lobules when needed. So there are a number of published studies on pneumatic compression devices and lipedema. There aren't a lot, and I think all of them are listed right here, so 5. And the problem with these studies is that they were primarily done in people's clinics. So a patient would come in, they'd collect the data and they'd note it, and then the next one would come in and they'd note it. Well, these people are getting all of complete decongestive therapy. So they're getting manual lymphatic drainage, they're getting tight bandaging, they're using pumps, they're wearing compression garments, and that makes it difficult to figure out what is actually effective and what's not effective, or do you need all of them to show any benefit in lipedema? So what we did is we designed a randomized, non-blinded 3-visit protocol. And it had to be non-blinded because we either put women in a pump or not, and you kind of knew if you were in a pump or not. These women were primarily stage 2 lipedema. They did not have any active vein disease, so you can't say that improvements were due to having improvements in vein disease. In fact, all of the veins had been treated. There were no clinical signs of lymphedema, and they were randomized to active compression with the LymphaPress Optimal Plus Pump and the LymphaPants. And we really wanted to use these LymphaPants because they treat not only the legs, but as you can see in the picture, they treat the abdomen as well. And I mentioned that I think there's lipedema on the abdomen, so we didn't want to leave that area untreated. In order to be fair, we had all women wear compression garments, and they all wore the same garment. So they were called absolute support leggings, and they were 20 to 30 millimeters of mercury high waist. We had this study approved by our institutional review board prior to enrolling any patient. The patients that were seen at clinic had presented to the Carolina Vein Center between 2021 and 2023 with a diagnosis of lipedema, and then they were called because they had expressed an interest in research. They had to be over the age of 18 years. 58 patients were invited to clinic, and at that time they did an ultrasound of the legs to make sure that they no longer had vein disease. And then 46 returned for the study, and all 46 completed the study, which was amazing. We used the WOLD criteria for lipedema. They all had a previous diagnosis of lipedema. They were all biologic females, and we made sure that the upper torso was spared of abnormal subcutaneous adipose tissue on physical exam, and that there was that mismatch between the upper torso and the amount of fat on the arms and legs. The increase in subcutaneous adipose tissue was symmetric, and the hands and feet were without evidence of lymphedema. And as I mentioned, we did assess whether they had vein disease by a venous duplex ultrasound, and all of them had vein disease and had been treated, except for 2 women who were in the treatment group who did not have chronic venous insufficiency. So our goals were, can a pneumatic compression device reduce lipedema tissue using an ultrasound? And that's never been done before. Could it reduce tissue volume by 3D imaging? Could it reduce tissue fluid content by bioimpedance spectroscopy? And would it improve qualitative measures, quality of life, pain, and other signs and symptoms in women with lipedema? I don't know why I have a football picture there, but okay. Our quantitative measures. We did leg volume by tape measure and 3D imaging. We used bioimpedance spectroscopy. So this is like bioimpedance analysis, but a little bit different, and it's kind of top of the line, and it's got qualitative measures at every single during every measurement that we do. So you know that the scans are very high quality, and it looks at total body water, intracellular water, and extracellular fluid. And then we do what's called an LDEX analysis, and that measures the risk of developing lymphedema in the legs. So we use the arms as our control because that's what we have, and we look at the risk of lymphedema in the legs. And then we did an ultrasound assessment of adipose tissue depth. That's all it is. How deep is the fat tissue on multiple places on the leg? And then we did some caliper measurements on the thigh and under the umbilicus. We also wanted to look at mobility. So we did a timed up and go test where you get up from sitting and walk. On the upper right corner, we had people walk on a carpet, which measures their gait. And then we used the lower extremity functional scale to see if women qualitatively had improvements in the function of their legs. We also did a SF36 measure and 11-point visual analog scales. So on a scale of 0 to 10, how do you feel in terms of tenderness, achiness, burning, stinging, tiredness, heaviness, etc. So this is the study, and I know it's kind of complicated, but we had them come in at visit 1, and we randomized them at that time. We gave them their compression garments, and they had to be off a pump for 30 days if they did have one. And then they came back for visit 2, which was the start of the study, and they did a lot of measurements before and after getting into the Lipoedema pump. And that was for the treatment group. The control group did not get in the pump. They sat with their legs up and they got to chit chat, read, watch TV, or eat a snack. And then for 30 days, the women in the treatment group went home and used their pump. And we have good data showing that they actually did use their pump at home. And then they came back for measurements at visit 3, which pretty much so duplicated visit 2. So here's the demographics of our women. And you can see that they're similar throughout. Their average age was 50, and their average body mass index was in the obese range. But we looked at their waist-hip ratio, and their waist-hip ratio was below the threshold for central obesity, which is great, and we need to use this measure more often. And their weight-height ratio was just under the cutoff for an increased risk of cardiovascular events in one study. In another study, it was kind of at the upper end of a mild risk. The stages and types that we enrolled are here, primarily women with stage 2 lipedema, and also they were type 3, so their entire leg was affected down to the ankle, and fewer had the arms affected, which was actually good because that allowed us to do our LDEX measurement with confidence that the arms were quote unquote more normal than the legs. All right, so here's our data. So this is our visual analog scale, and I know there's just a lot of measures here, but on the left-hand side, this is where we're asking him, do you have the tenderness, achy throbbing, burning, stinging, easy bruising? And then on the right leg, and then the left leg, same thing. And you can see on the left side, that's the control group. In the pink is the treatment group. And you can see the p-values are essentially non-significant for almost all of those measures from visit 2 to visit 3. And then in the treatment group, you could see that they had a beautiful and statistically significant change for all of the different measures. So this was amazing to me. I thought, wow, I wish I was getting a PhD and I had this kind of data. If you're more of a visual person, this is that data visually. So you can see there's only one significant change here in the treatment group in swelling and tightness, which I think is good because that reflects that compression garments do help with that feeling of swelling and tightness. And then you could see just the significant drop in the measures over the treatment group for the right and left legs. So leg volumes. So this is the LymphaTouch, and you can see that we're getting volume measurements at multiple aspects of the leg. So this is a very good representation of leg volume. And you can see that the blue again is the control group for the left and the right leg. And there's no significant change in volume for either control leg. But for the women who were pumping, you could see there are multiple changes here for the left leg that were significant, but no changes for the right leg, which was kind of surprising to us. But I think we have an explanation for that, and I will show that to you near the end. So here's your LDEX measurement. So we measured it at visit 1 and visit 2 before and after pumping, and visit 3 before and after pumping. And again, the blue is your control group, and you can see there's no significant change here. In the treatment group, we had a nice decrease in risk of developing lymphedema for the right leg and for the left leg. When we looked at total body water in the leg, and this is again by bioimpedance spectroscopy, blue being the control group, you can see that there's no difference in total body water in the legs for the control group, but in the left or right leg. But for the treatment group, we found a nice decrease in total body water for the left and for the right leg. So that's very consistent with our decreased risk for lymphedema. So then we went further because the SOZO machine that we used, our bioimpedance spectroscopy, tells us about intracellular fluid and extracellular fluid. So intracellular fluid means within your cells, and the extracellular fluid is going to be this interstitial space around the cells, but also within blood vessels as well. And again, blue is your control group, and you can see no change in intracellular fluid in the control group, but there were some statistically significant changes in the extracellular fluid in the control group. And again, I think this is actually a great because it reflects the wearing of the compression garments during the study and wearing 20 to 30 millimeters of mercury garments instead of the lower level compression. For the treatment group, we found nice decreases in intracellular fluid and extracellular fluid. And this was very interesting to us because it kind of forced us to figure out, what was going on. We really did not expect to see a decrease in intracellular fluid, so we had to do some research. And this is what we came up with. So this is a representation of a cell. So this is the nucleus where your DNA is, and this is the cytoplasm around it. And then the blue is the cell membrane. Inside, you see those little dots, those are electrolytes. And there's going to be more electrolytes within the cell than outside the cell. And water can flow freely across the membrane, and it's going to sit in areas where there are more electrolytes because those electrolytes have an osmotic pressure and they pull the water in. If there were more electrolytes outside of the cell, then the water would follow those electrolytes because that pressure, that osmotic pressure, would be pulling them out. And in this paper, and you can actually get this, this is a 2020 paper, and it's really helps you understand hydraulics and how cells respond to pressure. And I've always said fat cells respond to pressure. When you push on them, they learn to get smaller. And this paper actually supports that cells are very sensitive to hydraulic pressure around them. And this is an example of that. So they took a bunch of cells here at time 0, and they put pressure on them, 70 millimeters of mercury for about 2 hours. Now, what kind of settings would you use on a LymphaPress pump? You would probably use 30 to 40 millimeters of mercury. And some women with lipedema use 50 to 60 millimeters of mercury. So we're getting close to that 70 millimeters of mercury. So when you put pressure on the cells, their size decreases. So this is the cell radius over here. So pressure, their size decreases. You relieve the pressure, the cell size goes back up. Well, how does that do that? It does it by moving those electrolytes out of the cell across the cell membrane. So here you have potassium in orange and sodium in the blue triangles. You put pressure on the cells, the sodium moves out of the cell, so it decreases within the cell. Same with the sodium. Put pressure on the cell, sodium moves out, there's less sodium within the cell, and water follows. So the only way for water to move is if electrolytes move. And that is the reason for the volume change in cells, especially with pressure. So water moves freely across cell membranes between the intracellular and the interstitial space, only if there's a change in the osmotic gradient. So we think that the LymphaPress pneumatic compression device likely changed the osmotic gradient between these spaces, which is required for fluid movement. So the question is, do pneumatic compression device pressures improve the hypertrophic adipocytes that are in lipedema tissue? And that would be marvelous, because that's what we want to have happen. We want those hypertrophic adipocytes to go away, because metabolically those are unhealthy cells. So we did do biopsies in this study, and we actually are in the process of signing a material transfer agreement to have a really great group in the US evaluate whether there really was a change in adipocyte cell size. The other take-home message from this is that changing the osmotic gradient so that your cells decrease in size for longer periods of time may be better when you combine a pneumatic compression device with stronger pressures than just compression leggings alone. And you know, when we look in culture, we don't have the same fluid dynamics as in an entire human body. So in the human body, with those lymphatics pumping, those electrolytes may have moved out of the interstitial space and may not be available to move back inside of the cells, so those cells may stay smaller. So finally, as Sherry was talking about earlier, you know, there still is this question of whether there is edema in lipedema. And I think our data suggests that there is edema in the tissue of women with lipedema, and that this edema can be effectively reduced in multiple compartments, both within the cell and in that extracellular space, using a pneumatic compression device. So the other thing that we did, which was very different in the study, was to look at the depth of adipose tissue and see if a pump affected it at all. So we looked at the anterior thigh, and if you feel your anterior thigh, you know you have a lot of fascia in that area. And then also on the lateral thigh, where you have your IT band. And in the control group, we saw no significant change in the adipose tissue depth on the anterior or lateral thigh, but we did see a beautiful reduction in the adipose tissue depth on the anterior thigh in the treatment group, but not on the lateral thigh. And you can see we did get a reduction, it just didn't reach significance. And again, I think it's because of this fascia band here, and the skin is kind of close to it. And if that becomes fibrotic, it's going to be harder to decrease that adipose tissue. And I would love to hear from any therapists in the audience what they think about that. We also looked at the medial thigh, which has a lot less, you know, fascia. It doesn't have that superficial fascia. And we saw actually an increase in the control group, and then a nice decrease on the medial thigh on the right and left leg in the treatment group, and also on the medial knee, that darn medial knee that rubs as women with lipedema walk. So reducing that, I think, is super important for mobility. And finally, we looked at that pad under the knee in the posterior calf, which did not change in the control group. That pad under the knee also didn't change significantly in the treatment group, but that posterior calf did. So I think the difficult to treat areas from this data are that right over the IT band and that pad under the knee. And those are areas that we kind of want to think about. How can we improve treatment of them, both with the use of a pump and just in daily life? I mentioned caliper measurements. We measured with calipers in multiple areas of the body, and the only place we saw a significant reduction was in the treatment group right under the umbilicus. Calipers are really tricky. You really have to know what you're doing, and maybe we should have hired somebody who used calipers all the time to do the study, but I was really delighted to see that we did find a change in the tissue on the abdomen, because in another study we're working on, we found that women with lipedema really complain that their abdomens can be very heavy, suggesting there's fluid in that area as well. Finally, we did quality of life measurements, and we saw an improvement in physical function in the control group, again, which supports the use of compression garments in women with lipedema. And we saw a reduction in an improvement in physical function in the treatment group, but also emotional well-being and the role of emotion in people's lives. So when you're emotional and you don't feel like doing things, that's a big deal when you have depression or anxiety. So if pumping can improve your depression and anxiety and help you be more active in your life, that's, I think, priceless. And then here's, we also saw a beautiful reduction in pain and an improvement in general health with the use of compression garments, and then saw an improvement in energy, social function, pain, and general health with the pump. So the pump really seems to be doing a lot of improvements in the quality of life with lipedema. In our timed up and go study, we did not see any improvement in mobility. And so I think what we're doing now is looking at other measures of mobility for women with lipedema that can be done easily in a clinician's office or as part of a research study. But we don't think it's the timed up and go right at this time. But the one thing we did learn was that the time it took for women with lipedema in this study to complete the time up and go tests was similar to that for 80 to 84-year-old women in the Norwegian Tromsø study and in a meta-analysis of timed up and go data. So I think that really, forces us to think about mobility in women, muscles in women, and not just focus on the fat tissue. We did see an improvement in the treatment group with the lower extremity functional scale, and these are all self-reported measures, like it's easy to roll over in bed, get out of a car, go upstairs. So I think that was really good, and we'll continue to use this measure. So conclusions and discussion. Our main outcome measure really was volume. That was what LymphaPress wanted us to focus on. But if you know me, I had to focus on like 10 other things at the same time. But when looking at volume and total body water, our intracellular and extracellular fluid, we used the 3D imaging technology for volume and found no volume change in the left or right leg in the control group or the right leg in the treatment group, but we did see that significant volume change in the left leg in the treatment group. So we went into the literature and found the study by Steve Dean, where he looked at 440 people with leg swelling. 52 of them had lipedema and lymphedema. And what he found in his study was that the left leg was preferentially affected, whether you had unilateral or bilateral lymphedema, whether you had primary or secondary lymphedema, whether you had venous-induced lymphedema or lipedema-induced lymphedema. It didn't matter. That left leg was affected. And here's the anatomy of the pelvic area in a person. And you can see how complex it is on the left side compared to the right. That's the first thing. And then you see that, blood is flowing up in the blue veins here, and it's coming down in the red blood vessels. And here you've got your left common iliac vein on this side. And then look at that right common iliac artery as it crosses over that common iliac vein and it compresses it. And this can create fluid buildup in that left leg. And when it's severe, it's called May-Turner syndrome. And this can be relieved by stenting of this vein here. So what we think is that we did see changes in the volume of the left leg, but not the right leg, because there was more fluid in the left leg in women with lipedema. And so then we looked at the total body water of our entire population and compared the left leg to the right leg. And sure enough, there was a significant difference with more total body water in the left leg versus the right. So I think that that anatomy affects everybody. And when you do research studies, a main focus should be the left leg. But I do remember that a lot of my patients tell me, my left side's worse or my right side's worse. And we were looking at some more bioimpedance spectroscopy data, and we found that the right arm had less fluid than the left arm. And it turns out that a lot of more people are right-handed. And because of the anatomy, the right arm clears faster than the left arm. So our bodies are not as symmetric as we think. So one of the important outcomes of this study was that using the LipoPress optimal pump, we could reduce the risk of lymphedema development in women with lipedema. And this LDEX that we use, just to kind of give you an idea, like, is this really a useful measurement, or is this something, that's not so great? The LDEX values correlate with limb volume by perometry. They correlate with the degree of pitting edema. It correlates with lymphoscintigraphy, and it correlates with lymphedema staging using indocyanine green lymphography. So this LDEX is such a fast measurement, and it's very accurate and compares to many of the other measures of lymphedema that we have. And we found that both the left and right legs in women with lipedema significantly improved after the LipoPress pneumatic compression device. So I think this LDEX provides a strong link between lipedema and lymphedema in this study. We also found that the extracellular fluid decreased after compression garment use, confirming that compression wear is important in the treatment of lipedema. And I can't tell you how delighted I am that we were able to show this and support not only a active compression device, but also static compression. And that intracellular fluid didn't change in the control group. So I think we have a more long-term reduction in edema using an active compression device compared to just static compression alone. And also, we were able to reduce the size of the adipose tissue layer in multiple areas of the leg. I do think we still need to think about that area over the IT band. And as if you have, the therapists in the audience, what I notice is that there's a lot of nodules over the IT band, and women are very tender in that area. And I think that is an area of active fasciitis. And when you get fasciitis, you get fibrosis. And so that may be one reason why it didn't respond well. I'm not sure why that big lump under the knee didn't respond, whether the pump isn't accessing it completely. So we're looking into that. And we also don't know whether the adipose tissue actually decreased due to a reduction in cell size, or a reduction in fibrosis, or that interstitial proteoglycan gel, or tissue fluid. So I have the ultrasound sitting behind me, and I'm going to be looking into whether we can gauge a little bit better why that adipose tissue size decreased. But it's fun to think about. We also found that we got a reduction in tenderness or pain in the lipedema tissue, and it may be that there is a neuropathy due to inflammation in lipedema tissue. But we did find out that the LipoPress, that the active compression improved all of these signs and symptoms over that of static compression alone. So I just wanted to touch briefly on what is the inflammation in lipedema tissue. And I've been talking about that it damages the capillaries, there may be a neuropathic inflammation, that there may be a fasciitis. And we published a paper this year with Leon Straub as the first author, and we looked at RNA expression, proteomics, lipidomics, just as much stuff as we could to figure out what is the pathophysiology of lipedema. And we found no difference in inflammatory cytokines in women with lipedema versus controls. And I know they're really good controls because I picked them myself. So that was really interesting. That means that there's some other kind of inflammation going on that's not just cytokine driven. And this goes against a study published in 22 where they did find a change in inflammatory cytokines. What both of these studies did agree on was that there was an increase in oxidative phosphorylation and reactive oxygen species. And your mitochondria reduces your oxidative phosphorylation. And we know that when you have excess reactive oxygen species, it leads to oxidative stress, it damages cells, it damages tissues, and it exacerbates inflammatory responses that are ongoing. So my question after thinking about our study and reduction of inflammation, and we do have blood samples and urine samples, so we can measure inflammatory mediators. We're just being really careful what we pick because of results of studies like this that are very contradictory. Why is there damage in lipedema tissue, and what is causing it? And then secondly, should we be focusing on improving mitochondria in women who have lipedema, because that's what the data is really showing, and that's where there's a strong agreement. So finally, I'd like to say that I still am a proponent that there is edema in lipedema tissue that can be reduced by active compression, but also by static compression. And so therefore, compression garments remain a mainstay in the treatment of lipedema. And in women with lipedema, the LymphaPress Optimal pneumatic compression device with the LymphaPant, so treating the abdomen as well, reduced both intracellular and extracellular fluid, leg volume, adipose tissue depth, pain, signs and symptoms of lipedema, and improved quality of life. And this is the team on the top that actually did the study. Lindy McCutcheon is a gynecologist who changed her career and became a phlebologist and primarily treats veins. Her right hand in research, Carlos Zelaya, and then Marianne Somerville was a medical doctor in her practice and did a lot of the lipedema work before they sold their practice to the CVR, which is a company that works with veins. And then Tatiana Zimmerman is a trained ultrasound technician, and is just really, she's just really good at her craft. And so I really believe her data. And then Eric Anzart is the CEO of LymphaPress and was a huge supporter of the study and really made it happen. And then Deborah Gross from Mego Affect, which owns LymphaPress, helped us in every aspect of the study, no matter what we needed her for. So thank you so much.
On behalf of everybody here and all the people who are going to watch this recording, a huge thank you.